This afternoon, we are going to talk about acute appendicitis. My name is Dr. Gakwaya. The audience is clinical students and practicing doctors. The objectives are to produce a doctor who is able to treat a client with acute appendicitis effectively and safely, to pass examinations, to prepare for postgraduate, and to be a lifelong learner. Learn outcomes. To describe acute appendicitis, to recognize the burden of acute appendicitis, to identify the etiology of acute appendicitis, to identify the pathophysiology of acute appendicitis, to be able to classify acute appendicitis, to identify the clinical features of different stages of acute appendicitis, to recognize the possible complications, to differentiate acute appendicitis from other diseases that may mimic it, to choose the correct surgical and medical treatment, to recognize specific post-operative complications. The methods I'm going to use are PowerPoint presentation, illustrations, and author's audio. The plan I will follow is introduction, epidemiology, etiology, pathophysiology, clinical features, investigations, treatment, complications, prognosis, and prevention. Introduction. Acute appendicitis is a common emergency. It is difficult to diagnose in the children and in the elders. It is a differential of acute abdomen. Anatomy. The commonest is retrocecal appendix. Otherwise, it has different positions: pelvic, subcecal, pre-ileal, and post-ileal, in that order. Epidemiology. It occurs in all countries. In the 1940s, it was rare in fragile countries, but with adoption of the European lifestyle and diet, incident has significantly risen. Age. The peak is around 30 to 45 years. Sex. The male to female ratio is 1:1. Etiology. Obstructive. Foreign body, for example, small seeds of watermelon or passion fruits, fecal leaf, calculus, mucocele, tumors, and ascariasis. Non-obstructive. general infections, and this is the commonest. Pathophysiology. The following are the cyclic changes that occur: edema and mucosal ulceration, bacterial translocation, inflammation, obstruction of lymphatic flow, policeman moving to form an appendicular mass, which later on may become an abscess, vesicular obstruction, ischemia, gangrene, and possible perforation, contamination of the pelvic cavity, and finally localized or generalized peritonitis. During the process, there is swelling, increased intraluminal pressure, compression of the vessels, and bacterial invasion. Symptoms. The common eye symptoms are: the client feels unwell, there is loss of appetite, some have pain and discomfort around the umbilicus, and this is basically referred pain. There may be flatulence and bowel irregularity. Later on, there is a sharp pain localized in the right iliac fossa. There is low-grade fever. There is nausea and vomiting once or twice. Finally, if it forms a mass, an abscess, may go gangrenous or may perforate. All these increase, particularly fever, to a high level, and the client deteriorates. In special cases, like children, it's difficult to get a good history. Pregnant ladies, the appendix raises up in the peritoneal cavity. Diet. A history of eating lemon, passion fruit seeds should be sought because they can obstruct the lumen. Elderlies. It is difficult to get a good history because of loss of memory and dementia. Slide 3 shows McBurney's point with the migratory pain. Signs. Early, the temperature is about 38 degrees centigrade. The radial pulse is fast, about 80 beats per minute. The tongue is fat. The client lies with the hips flexed and knees drawn up for comfort and is motionless. If the client is requested to stamp hard his right foot, he'll fail because of pain in the right iliac fossa. If he's requested to cough, he'll feel pain in the lower abdomen, which is called Duffy's sign. There may be guarding, a mass, tenderness, rebound tenderness in the right iliac fossa, maximum at McBurney's point. The following signs indicate the position of the appendix. Pelvic appendix. There is pain on internal rotation of the right thigh, so-called obturator sign. Then a retrocecal appendix. There is pain on the hyperextension of the right hip. There are two other common signs illustrated below. Loving's sign and Rodriguez's sign, or Vickrey's sign. Rectal examination may be tender if the appendix is pelvic or if there is a pelvic abscess. McBurney's point illustrated. It is 2/3 from the umbilicus on the line joining the umbilicus to the anterior superior iliac spine. Loving's sign is illustrated. You put pressure on the opposite side, left iliac fossa, and you feel pain in the right iliac fossa. Rodriguez's sign is illustrated in figure 6. Slide 7 shows the iliopsoas test and the obturator test. Part 2. The common complications. The following appendicular complications may develop. Mass. This is formed by the appendix, loops of intestines, inflammatory exudates surrounded by the great omentum in order to localize and control the infection. Abscess. When the above mechanism has failed, an abscess forms. Ischemia and gangrene. This follows increased compression of blood vessels due to increased swelling. Perforation. When it occurs, it contaminates the peritoneal cavity. Peritonitis. Peritonitis may be localized or generalized. Slide 8 shows an appendicular mass. Slide 9 shows an appendicular abscess. Slide 10 shows gangrenous appendix. Slide 11 shows a perforated appendix. Slide 12 shows peritonitis. Alvarado Score. It is a clinical and laboratory method used to standardize the diagnosis of acute appendicitis. It has undergone a number of modifications. The most recent does not include the shift to the right so that the total is 9 instead of the old 10. It is called the modified Alvarado Score, abbreviated as MAS. The specificity are as follows. They've got a symptom, then the variables, then the scores. Migratory pain scores 1. Anorexia scores 1. Nausea and vomiting scores 1. Then signs. Tenderness in the right iliac fossa scores 2. Bone tenderness scores 1. Temperature above 37 scores 1. And laboratory. White blood count above 10,000 scores 2. And shift to the left, more than 75% scores 1. And the total is 10. So when it is modified, the shift to the left is excluded and the total becomes 9. So 5 to 6 becomes compatible, 5 to 7 to 8 becomes probable, and 9 becomes very probable. Mnemonic for MAS is material. M for migration, to right iliac fossa. A for anorexia. N for nausea. T for tenderness. R for bone tenderness. E for elevation of temperature. And L for leukocytosis. Mantra. Differential diagnosis. Refer to acute abdomen as discussed before. Slide 13 shows an acute abdomen. Investigations. Neutrophils are highly increased. Abdominal ultrasound is useful in late stages. CT scan is useful in complicated abscesses. The diagnosis is mainly clinical. Do not lose time doing a lot of investigations. Ultrasound showing an abscess in slide 14. Treatment. The treatment depends on the stage when the client is diagnosed. And the stages are quite many. Acute appendicitis, appendicular mass, appendicular abscess, gangrenous appendix, perforated appendix, local generalized peritonitis, appendix in children, and appendix in pregnant women. Some of these are clinical and others can only be discovered in theater. Acute appendicitis seen in less than 72 hours. You do preparative preparation, prophylactic antibiotics, for example, intravenous metronidazole, and immediate appendicectomy. Appendicular mass. You do nearby os, nasogastric tube for suction, and intravenous fluids, intravenous antibiotics, particularly against gram-negatives, e.g. gentamicin plus metronidazole. Then you monitor the size of the mass, the vital parameters, and the general condition. If the client is deteriorating, you explore. If the client is improving, is discharged, an interval appendicectomy is done after 4 weeks. Appendicular abscess. Drain by the most direct route to avoid contaminating the peritoneal cavity. Take a pulse swab for culture and sensitivity, and a corrugated rubber drain or tube is left in place. Administer antibiotics. One may change according to results of culture and sensitivity. Interval appendicectomy is done 4 weeks after recovery. Gangrene. This is discovered in the theater. One does wide resection, including part of the cecum. Slide 15 shows a drainage tube. Appendicular perforation. This is also discovered in the theater. Wide resection and closure is done. Local or generalized peritonitis is suspected clinically and confirmed in the theater. Laparotomy is done. Peritoneal lavage with the warm saline is done. A perforation is looked for and closed. A pulse swab is taken for culture and sensitivity. Antibiotics are administered. Interval appendicectomy is arranged 4 weeks after recovery. Incisions. Immediate surgery. For immediate surgery, laparoscopic surgery is commonly used. In the past, grid iron or Lanzer's incisions were popular. Interval appendicectomy. Low midline incision is used in the fear of possible adhesions. Postoperative complications. Early atelectasis, pneumonia, paralytic areas, wound infection, intra-abdominal abscesses, portopyemia, and deep vein thrombosis. Late complications. Right inguinal hernia, incisional hernia, intestinal obstruction, mucocele, recurrent appendicular pain. Prognosis. In most centers, appendicitis is relatively safe with a low mortality rate. 8 per 100,000 in non-perforated, and 51 per 100,000 in perforated. Recurrent appendicitis. Thorough investigations are done to confirm the diagnosis. Chronic appendicitis. It is a difficult diagnosis to make because one needs to demonstrate chronic inflammatory cells in the appendix specimen. Chronic inflammatory cells are rarely demonstrated. On the whole, as an entity, chronic appendicitis is a rare diagnosis. Ladies and gentlemen, thank you for listening to me.